Welcome back to Health Policy Off Script, where we take a hard look at Canada's health system, what's working, what's broken, and what needs to change. Despite decades of reports, commissions, and promises, Canada's health system still isn't meeting the needs of the people it's supposed to serve. Why is implementation our Achilles heel, and why can't we turn evidence into action? Stephen Lewis, Ivy Bourgeault, and Dale McMurchy are here to pull back the curtain on why transformative change in Canada feels so hard and where the real opportunities lie. We're not just naming the problems, we're talking about what can actually be done. This is Health Policy Off Script. Let's get into it. I am a member of the public.
As are we.
Maybe a little more informed than the general public, but by no means would I consider myself to be an expert in health policy. To get this conversation started, let's address a few issues that have happened recently. Bill 2 in Quebec. In my opinion, one of the biggest issues that came out of Bill 2 in Quebec is that we are afraid of being fired or forced to resign. Quickly, without offering opinion, Bill 2 from late 2025 was a health reform that aimed to improve access to doctors and changed how doctors were to be paid. Some of the pay was to be tied to targets like meeting wait times and patient rosters. One of the more controversial aspects was that there would be penalties for doctors who failed to meet targets. Many doctors' associations and colleges felt it was too strict and unfair. In the end, Quebec Minister of Health, Christiane Dubé, resigned over this bill. Another program I'd like to discuss is Prescribe It, from Canada Health Infoway and TELUS Health, which is being shelved by Health Canada. This program was designed to upgrade communications between doctors and pharmacies. In simplest terms, this program removed the need or desire for fax machines. Yes, I said that. Has anyone under the age of 40 ever used a fax machine? But there was only a 5% adoption rate, meaning all of our prescriptions are still being faxed or hand-delivered to the pharmacy.
Yeah, I think the cross-cutting theme is being afraid to do something differently. Want to encourage people to be bold. How you go about doing that is very important. And I think some of the cautionary tales that we hear, what might be a cross-cutting theme of that, is that the how was done more in private. If you want to bring about change, you really need to understand sort of change management 101. How do you engage with people? How do you enable them to see themselves in the change and that it's something that they want? And sometimes you have to modify the change that you want based on the feedback that you get. When we want people to be bold, we need to also complement that with what is the best way to go about implementation. And personally, I think the more that you do that, not in closed doors, like not completely out in the public, but some, input from those who are going to be mostly affected and that you need to get on board would be an important strategy.
The thing about Quebec, it's a cautionary tale, but I don't think it was about fear. I think it was about bad strategy. I mean, they did it. And it's an interesting dynamic here because if you went to these members of the public in Quebec, and there are 1.5 million people in Quebec, at least, who don't have access to a regular source of primary care. If you said to them, do you think it would be a good idea if the government figured out a way to speed up this enrollment process and make sure we have access? I'm sure 95% would say yes. It's terrible that so many, probably 25% of adults, don't have one. So then the Quebec government said, yeah, we're going to do this. And Bill 2 was the boldest piece of legislation since Medicare. It's probably bolder than the Canada Health Act in some ways. And they immediately lost the battle. And the question that it raises for policy is, how do you win the public battle? There was a poll shortly after Bill 2 was released that showed something like 49% of the public was opposed, maybe 28% was in favor, and the rest undecided about whether this was the right thing to do. So in a sense, you could say, wait a minute, the public is sort of voting against its own interests because doctors pushed back. Whom the public believes and whose story, whom does it trust really matters here. you need to get that straight, and you need to figure out how to get the public aligned with what seems to me in this case clearly in the public interest before you go ahead and plot out your next steps. You need to play chess, not checkers in the old adage. I think Dubé really wanted to press ahead, and the government backed off. And this was a government that is already wildly unpopular. So, in a way, it didn't have much to lose trying something bold. So, in an odd way, a government in a desperate political situation it has a winning condition for doing this because it's not doesn't have any social cap or political capital left. But on the other hand, I think it has a credibility problem.
This is a tough one because the discussions we talk about the change management and discussions behind the scene in various ministries of health about doing wholesale reform in primary care. There are just some unwritten no-go zones when it comes to the way in which medical associations will react. And so that a lot of these bold ideas or potential for change, they're just, in some instances around the table, that they don't go any further. That's just not going to fly. What's the balance in terms of pushing a little further and digging in your heels, but bringing everybody along? I don't know. I'm putting it out there.
And further to that, I think it illustrates you can't have a vision for transformative change and implement it, even if you have guts and even if the public approves. Everything is negotiated. And structurally, to imagine that you can negotiate the kind of system that every report recommends by sequentially negotiating with 10 or 20 or 5 major bargaining agents with their own interests and their own history and their own strategies and their own corporate memory about how to negotiate, that's a bit of a fiction. So if you don't have a unified group of negotiators that you're negotiating with, those parties, if they're not on side for all of this and say, we are part of the problem, this whole structure is on all of us, and without pointing fingers, say, we have to do things different too. When have we heard a major health profession say, we're partly responsible for the inefficient division of labor. We agree that we have neglected rural and remote Canada forever, and there have been chronic shortages there. And it's kind of on us when primary care physicians appear not to want to work in full-time family practice anymore. So let's all just sit down and change.
Absolutely. Well, there's a whole process to change. One of the things that was happening when we were doing team primary care was there were announcements that were being made that really set us back. And here's where I find, when there's a bold change that's made, you haven't engaged all of the different members who are going to be impacted in that change, and you get the typical response. So, case in point, when we had team primary care, Alberta was making announcements. Well, you can go and see your nurse practitioner instead of your family physician. Same thing was announced in Ontario. You can go and see your pharmacist instead of having to, quote unquote, wait for your family physician, assuming you have one, right? And this whole substitution just gets everybody's backs up. How it is that you engage with all of the different practitioner groups that are going to be impacted by a policy, what's in it for them so that they don't criticize the policy, and you fix the policy or you amend the policy to make sure that they are getting something out of it. Again, everybody is in a system of dismay. So if you can figure out what is one thing from a new policy that might get them on board, I think that's important. And then having an effective communication strategy to get that out. Avoid, certain triggers, but still be able to kind of move forward.
One of the other challenges is, Ivy, you mentioned change management 101. I think we're way past 101. We've been working for a long time trying to make change, and it's hard. It takes time. And the longer and the harder and the more disruptive it's been, the more entrenched people have become. So a few people like ourselves have been around the block a number of times. And if we don't give it enough time and these things don't come to fruition when we expect, we kind of throw up our hands, start something else. So there needs to be, that sort of stick with itness.
Absolutely.
We need to be applying change management. What is it? Fourth year change management, not 101, and really think about what needs to be involved, bold leadership, and having those leaders, someone's got their back.
Well, and I think that's really frustrating is when you have a policy and it's a good policy. We need to get there. We need to get away from people bringing in paper copies of their prescription or fax. I mean, it's still remarkable that we're still talking about this in 2026 when we are also thinking about what are the impacts of AI, on the system, that it's the right policy. You've hit a roadblock, and implementation of any innovation, and I wouldn't really call that particularly innovative. I mean, it's just where we need to go. But to retreat is to say all of that money we invested, we have no return on that investment. And I'm not a health economist, but we could also think that, there's sunk costs and there's stick-to-itness, as Dale mentions, about investments.
I think, though, there are limits to consultation, bringing people along, because we do a lot of consultation in healthcare for most things.
But then we don't move on it. But yes, 100%.
Well, we don't move on it, and it's also voluntary. Every province, or most of the big ones, have set up not only a provincial quality council, but large health organizations in particular all have quality improvement people embedded in their organizations. The system still isn't visibly better to the extent that we measure it in quality than it was 20 years ago when all of this got started. Even before that, there were clinical practice guidelines, there were care pathways, we have Choosing Wisely Canada, we have all of these evidence organizations that say, look, we have very high quality evidence in these areas, and yet all the adoption is voluntary. We still have big variations in practice. We still don't have any systematic approach to appropriateness of care. So there is something about this that the people who work in the system somehow have a feeling that is correct, that the policymakers aren't that serious at the end of the day. And conversely, when there are circumstances where you don't have a choice or where the policy is actually clear, it's incredible how things that everybody said couldn't be done quickly were done immediately. The most obvious one is virtual care. When the pandemic hit, all of the practices that said, we can't do virtual care, it would be unacceptable to our patients, and that's not how we want to practice medicine. In 3 to 4 weeks, the entire system went virtual, and it didn't collapse. We have a culture where policymakers have had a tough time making things stick, and have shown that if there's a lot of pushback, they won't do it. And that's one of the dangers of consultation that's kind of for cosmetic purposes. I mean, what interest groups do with consultation a lot of the time is to say, here's where our lines in the sand are, and don't you cross them, and then we'll play ball. It's not, can we collectively figure out a way to do things better? Can we agree on what we're trying to achieve here? E.g., Quebec, we want everybody to have a primary care home. Now, you're going to come here and argue that it's a numbers problem, and we won't, and we will argue something else. But can we all agree on that? And then we will sit in the room in good faith with all of the occupations involved in primary care and figure out how to do that. And if we end up at an impasse, fine. But if you don't like our solution, you tell us what your solution is. I mean, empower people to come up with a solution and make them accountable for having it. I think you have a better chance. Government should be very clear about the objectives and tell the public, these are the objectives. This is how we will monitor and measure it. These things must be done. Does this sound reasonable? I think it would be an easy sell to say, of course, that's reasonable. Nobody wants a circumstance where they perceive some loss. when primary care docs were very underpaid compared to specialists, and said, well, there's a remedy there. We should compress the incomes. And organized medicine said, we agree entirely. Nothing's coming off the top. You can pay primary care docs way more money and we'll be cool with that. But if you take $20,000 a year off a $700,000 a year orthopedic surgeon or $1 million a year cataract surgeon, we're going to fight you. So that's the other problem, right? That the history of throwing money at problems to solve a problem instead of saying, no, we need to reallocate some money. That is always a big sticking point too.
I think the consultation that you describe, Stephen, is exactly what I was thinking about. And I think it's very much in keeping with the tight, this is where we're at, these are the inputs, this is how much money we have much loose in terms of how you implement change, and have, yes, the right people at the table having those conversations, and very clear outcomes for which you are accountable. You know, when we write policy briefs, one of the policy options that we include is stay the same. And I think that we need to say that is not a policy option. The status quo, there has to be some kind of change coming out of this consultation, and it can't be the status quo. This is a reason why it's enormously frustrating. These examples that Matt brought to us is that there was an opportunity, and then it came back to the status quo. And everyone's going to have some gains and some losses out of that. And I think, you know, everybody has to pull up their big girl and big boy pants to acknowledge that that is going to happen, but we are all in this together and to try to move forward. The other issue, the really importance of the accountability at the end, is sometimes there are unintended consequences of policies. And if you're never evaluating the outcomes, that there aren't clear outcomes and evaluating them, you can't course correct if there isn't that tight at the end.
Do we actually have a roadmap for what we're trying to achieve with the Canadian healthcare system? Do we have an overarching strategy? Do we have an implementation plan? Have we made the case? Like, how are we going to make our lives, our providers' lives, and patients' lives better? I did the evaluation for family health teams in Ontario a while back, and we did lots of statistical analyses with all sorts of variables and outcomes. And one of the things that popped out as a predictor in statistics of better patient outcomes was whether the staff and the team had a common understanding and knew what the mission and vision of the organization was. Now, we usually just think that's fluff. Yeah, we're going to sit around and brainstorm, but that actually means something. And I think we need that on a national and provincial and within each service to really acknowledge that we need to kind of step back and say, what are we trying to achieve? And then not be so risk averse. Often we throw out the good in search of perfection. And the other one is we fail to acknowledge the incredible knowledge and expertise on the ground.
Absolutely.
There is that rigidity in the system. We know we keep coming back to that, like tight, lay out the objectives, have at it, and then we're going to measure. But we actually undermine ourselves, and the trial and error that happens during implementation that actually makes it better. And this is kind of alluding to our, do we do it in small chunks or do we do the big bang? And we need to actually unbridle what's happening on the ground, because there's some really cool things that we are stymieing.
I really struggle with this. If I can make changes to my house that'll improve the efficiency of my heating system by 25% and see ROI in 3 to 5 years, I'll do it. But in healthcare, we want to see 100% improvement in efficiency.
We have this saying in academia that, the best thesis is the one that's done. The perfect one is not, right? And so it speaks to that point that Dale's talking about. We have institutional amnesia for the various, reports and the important findings and the lack of follow through. So then we rinse and recycle and have another group, do another set of consultations and write a report. I thought Dale's comment about a roadmap was a really nice segue between these sections. And I think it gets at, the comment that you made about incrementalism. I'm not against incrementalism, right? You have to, take one step at a time to climb a mountain, but that there's a mountain and that's your goal. If you don't have a roadmap, you don't know where you're going in the incrementalism. For me, what I see is the opposite, my other least favorite term, low-hanging fruit, right? And low-hanging fruit doesn't give a sense of like, how are you picking fruit from the tree to keep the tree healthy? It's just, we just keep picking things that are easy to do. Now, if you have a roadmap and you have an incremental approach where you say, okay, we're going to do some low-hanging fruit, and I'm doing air quotes here, but those low-hanging fruit are going to get you some quick wins along that path towards, climbing this mountain where there's some clarity where you're going. I think that's different. There are many examples in health policy, in healthcare, where it's very ad hoc. There isn't clarity on the goal, a shared goal, and a roadmap to that goal, where everybody has a role to play, building a puzzle, and they have a piece of a puzzle, and they need to put that puzzle in place before we can move to the next stage. Again, it requires that honesty, that rolling up the sleeves, and having other people in the room, as Stephen has said.
Part of it to me is related to data and information and curiosity. And this goes up and down the system. I mean, when you ask Matt, why do we settle, or why are we not interested in a 25% improvement if we think it has to be much bigger? I wish it were that simple. I don't think people are even curious about their performance in a lot of ways. When you look at a typical primary care practice in this country, how many get continuously updated data on performance indicators that they themselves designed? We are operating partly in an accountability-free world because we don't set clear targets. And then when we do, if they're measured, they're not widely reported. And when we do get health information reported, it's at a level that isn't actionable. So, don't tell me, it doesn't help me much if I understand the provincial rate of something good or something bad happening, because there's a lot of variation within. That's not the level of the level of action is not the province, it's the organization. You can only improve things in your own performance when you know your own performance and you know how it compares. And some high-performing systems, all high-performing systems have that in common. They have an information system that drives it and that is co-designed. The other thing is we have the phoniness of it, and we talked about this last time. If you have 150 indicators, you have none. What are your top 5, and what do you hold yourselves accountable for? And if you want to, you can make the whole system better eventually by getting used to succeeding at a few things. So again, that can be quite incremental, but you have to be dead serious and have a sense of urgency about the totality. And there isn't, right? I mean, the sense of urgency is almost always about access. And that's one of the Achilles heels in Canada. I don't think anybody is interested in a conversation about quality and high performance when you have an access problem. What they're saying, give me a break. It takes me 6 weeks to see a primary care provider, if I can see one at all, or I may have to go to the emergency room for this. So no, that doesn't mean much to me. So I think it's all of a piece on the implementation side, and making something small excellent is not impossible, and it's done every day in Canada. Making the entire system excellent is incredibly difficult. So we need a halfway point in there. Can you make the whole system? Can you move the entire performance curve to the right to a certain extent? And I think the answer is absolutely yes. Could you solve the access problem if you took it as seriously as we should, and if you said this is a national emergency? Because I think, we may throw around the crisis word and the breaking point word too much, but I think it's apt here. The whole promise of Medicare was universal. It is not universal. It is not universal at the front end when it really has to be universal. If 25% of people, or whatever the actual figure is, have either no access or terrible access, is not an existential threat to the system, then there's no such thing as an existential threat to the system. So if everybody said, look, we're taking this seriously. And if in 2 years, Quebec said 1 year, if in 1 year we don't solve most of this problem, this is failure. And we are going to try something unprecedented in Canada. We are going to throw our weight around and say, look, you're taking extra patients because you don't have very many in your practice. And yeah, someone can assign them to you. Now, this is, of course, draconian stuff, but who's the system for at the end of the day? When you have a clash of here's a bunch of patients who don't have access to primary care, and here's a bunch of providers who don't think it's their job collectively to provide it, and you have to decide who are you going to act on behalf of. We saw who won that battle in Quebec. That was the provider side. And I think the missing ingredient here is, how do you frame this implementation problem? And is it all that complicated to implement this? Well, it's not trivially simple, but nor is it quantum physics. You just create obligations that you didn't have before, and you have to meet them.
Academics draw fancy curves about this, right? So you've got the early adopters when you come to implementation. Then you get those in the middle who kind of follow along, and then you have the laggards. We need to figure out what it is and why they're not joining the party. And then I'm going to put it out there. Well, have we actually tried incrementalism and it's not worked? Do we need to Tommy Douglas some of this stuff? Is it time for wholesale redesign? And if so, what does that look like and in which parts of the system? Because at the same time, we need to continue to have and promote innovation and people taking risks and tweaking around the edges and experimenting with small changes. And we can't have that rigidity in the system that doesn't allow that to happen in any meaningful way. So many people I hear who are administrators or providers are saying, well, I'm trying this, but, I'm taking the risk because I'm not, I'm not asking permission first. So how is it that we can kind of promote that continuing tweaking and innovation? At the same time, maybe there is a bit of a, wholesale redesign that we need to put our boots to the ground and attack.
So, Dale, I'm going to let you kind of continue your thoughts here, but how do we finish this conversation off with providing a little bit of hope and a little bit of guidance?
I think the main thing is the bits are all there, honestly. And I think the three of us have, been around the block enough that we've seen it. There are amazing people doing really great things every day, but some of them are a little bit on the merry-go-round or the hamster wheel. But there is a lot of potential and a lot of desire to make change out there. And I think one of the key things is that bold leadership, and that bold leadership that is given the freedom to actually make change, to take risks. And again, as I mentioned before, a leader that's actually put out there to really inspire people, but we have their back.
Well, I think that we could think of leadership as distributed leadership. Everybody has a role to play, right? And I'll come back to your comment about a roadmap and building off of what Stephen was saying. At minimum, we should have access. At minimum. And then we should move towards higher quality, right? So that's a roadmap that we can work on. I think that there needs to be alignment across the public, the healthcare professionals, the policy decision makers, and some opportunities to create that alignment would be really important. I want to speak a little bit about some of the other themes that we addressed here. Evaluation is an uncomfortable thing, especially if you're evaluated and you're not meeting targets. And what's very interesting is that health professionals, when they go through their training, are constantly evaluated. If we could extend that socialization, that you will have continuing professional development, that you will continue to be evaluated, that's already built into their training. We just have to extend it out. So maybe some, reverse mentorship of early career people who have just come out of a program and are very motivated and have built in that socialization to evaluation, work with practitioners who have been in the field for a while, I think would be an interesting potential solution going forward.
And to add to that, I think, Matt, there is a structure to this that I think makes it easier if there is the good sense, and in some senses, courage to do this. We had it with regionalization in theory, but we never did it in practice. The whole point of regions were to integrate all the services, which everybody has called for forever. But what got left out? Physician care, primary care in particular, was never part of the continuum, which is a fatal blow to integration. It was dead in the water right there. And the second is you have to trust people. If you want creative visionary leadership, let's say at a regional level, we've moved in the system on the financing side to say we're going to pay for activity. We're going to know every widget, and this is our vision of idea of productivity is we're going to buy 28 hips and we're going to buy 32 of these, and we've moved away from global budgets. And this is a heretical thing to say now. I think a global budget with accountability is far better than micro accountability for buying little bits and pieces of service. It's the fatal flaw in fee for service is that you essentially turn physicians into bean counting practitioners. 2/3 of physicians at least, and now probably more, say we have had it with fee for service, and yet it persists, it persists, it persists. We can't even get rid of the most basic perverse incentives that have driven our system forever. So it seems to me you need to be serious about giving people the license to do things better. And you have to, I think what Ivy said is very critical on the evaluation. There is more organized continuing education and evaluation of McDonald's employees than there is of people in healthcare. I mean, how many doctors get an annual performance review that is systematic, formal, and data-driven? This is what high-performing, quality improvement-oriented organizations do. And that's clinical policy. We think of policy as a big picture thing of government that you have to have 98% access in 5 years, which is, of course, important. But where the actual improvement gets done is on the ground. And it is that intermediate level of policy. You have to follow this care pathway. You have to, in your earlier example, we're not having fax machines in here anymore. And here's the target date, and we're all going to operate on the same system. And it's too bad if you have a legacy system that doesn't talk to anybody else. That's over. Yeah, there's a lot of power, understandably, vested in the people who work in the system, and it is extremely important to pay attention to them. But you also have to make them responsible for fixing some of this stuff. Instead of saying, here's the solution, you have to do this. As we've been saying all along, here is the problem we are trying to solve. Here is the outcome that we want. You guys figure it out. Our first step, our first approach is always, you figure this out and come up with a solution. Then we will co-design the parts of it. Your solution has to have these 3 core elements, but it doesn't have 95. And we are completely agnostic about how to do this. And anything that works, we're fine with it.
The path to transformation is right in front of us. Will we take it? Thank you for listening to Health Policy Off Script.